Muchas gracias. Vamos a tener una sesión de preguntas y respuestas. Si me pueden subir la pantalla, por favor. And we invite our panelists to come to the front, please, to see. ¿Hay alguien en el auditorio que quisiera hacer alguna pregunta a nuestros ponentes? Tenemos un micrófono.
Dr. Abu, can you consider the combination of any drugs of chemotherapy with immunotherapy? And then don't any studies about it?
Well, thanks very much.
Andrés Macari Jorge.
Thank you very much, and I would say probably already Dr. Allen showed the picture from one of the trials that we did, which was the doxorubicin plus sorafenib, which sadly, even though the phase 2 trial that he kindly showed followed a phase 3 trial that was done part of the Alliance cooperative groups, was negative. And I would say this kind of really told us that chemotherapy does not work in that disease. Now, that's a perspective we have. On the other hand, FOLFOX is already approved in China as a first-line therapy for liver cancer based on a study that they did in JCO versus doxorubicin. So now there has been efforts, and we are aware of them, of combining FOLFOX with certain checkpoint inhibitors or even certain TKIs or certain other antimetabolites for HCC. But I wouldn't say that we have anything that is yet considered a standard in that setting. Yeah.
¿Alguien tiene otra pregunta para nuestros ponentes?
First in Spanish. Si podemos adelantarnos en las estrategias de tratamiento que se vislumbran en el futuro, ¿cuál sería su estrategia favorita? La combinación de dos moduladores de inmunoterapia, el TKI con inmunoterapia o el antiangiogénico con inmunoterapia. So, which would be your preferred treatment strategy, provided that the patient is eligible for the three strategies, like the immunotherapy plus bevacizumab anti-angiogenic, or the TKI with immunotherapy, or the combination of immunotherapies?
So thank you, David, for the question. It's a little bit too early to decide which one we favor, and it's going to become a little bit more either just what I like or what I have experience with. But at least let me give some notions. The bevacizumab is no doubt nerving people because of the potential for the bleeding, especially from esophageal varices. As we all know, bevacizumab was studied by itself in HCC, and the study actually was negative, but at the same time there was quite a bit of bleeding because of the varices. When this study happened, the IMbrave 150 took place, they made sure that they screened everybody. And as such, good for them, there was no concern for bleeding on the study, but the study was not the real world data. And the question is, what will this translate into when we really have the atezo-bev in the real world? That's the concern which even the lead of the study and the sponsor of the study are concerned about, because as we all know, when you scope somebody, it's not like going to be black or white, like on, off, yes or no. There's a big spectrum of potential varices that we don't know how to interpret. So we have to wait and see for that purpose. On the other hand, I would say the lenvatinib plus pembro is no doubt intriguing, but interestingly, the durva-tremi is very intriguing because, interestingly, you did not touch yet any TKIs, and you keep choices for later on. And would it be that another will be the answer to checkpoint inhibitor as a first-line therapy. Again, these are speculations based on whatever data we have, but I think we just have to wait for the data.
Thank you very much.
¿Alguna otra pregunta?
Congratulations for your presentation. Actually, my question is related to the surgery approach. We know that it's very challenging for the pathology doctors really to check the margins of the resection. What happened? Well, actually, you presented a curves related that to take out the majority of the tumor is really impact positive for the patient. My question is related. What happened if in your final pathology result you got a positive margin? Is your next conduct would be just expectation, surgery, or some kind of chemotherapy?
Yes, well, I think in the patients that we are taking to the operating room are typically patients who I would say are very early along in their disease process, both from their liver disease and from their malignancy. In the setting of a positive margin, particularly if we believe there was gross resection of the tumor, my typical response would be observation. I certainly would not go back to the operating room. That is fraught with difficulty and nothing but misery, both on the patient and practitioner's part. The roles of systemic therapies, obviously in patients with a very small solitary tumor in the liver that's resected, we generally would not. But obviously these patients who are very high risk for recurrence, these patients with intrinsic liver disease. So these patients need to be monitored and followed very carefully. And with future recurrence or new lesions within their liver, obviously different treatment approaches such as systemic therapy or even liver transplant would be entertained.
Regarding local therapies, do you have any protocol with radiotherapy, SBRT with immunotherapy?
So I probably would ask kindly Dr. Crane to answer this, because together as colleagues we have worked and developed ideas about combination of the immunotherapy or checkpoint inhibitors plus radiation therapy, and maybe Chris will be the right person to answer that. So,
Dr. Harrison.
Thank you.
So I think it's a promising area. That's a promising area of future investigation. There's a very good possibility that radiotherapy and immunotherapy will work well together and produce a systemic effect. But there are many outstanding questions, and I'd say that area of investigation is in its infancy still.
In terms of surgery, I would like to ask your comments when there are more than one lesion in terms of embolizing before, the post-op, and the facility and the reason of better embolizing before doing the surgery.
Yes, I am not, I think resection in multifocal disease is not something that we are typically doing. I think we generally defer to embolization therapy in multifocal tumors in general. There are patients with limited multifocal disease, bifocal disease, I guess, 2 lesions, who are ideal candidates in terms of their liver function, where I believe resection can be appropriate. but I would say in general, for multifocal disease, particularly multiple small tumors, we would consider embolization as a definitive therapy. The type of embolization depends on which hospital you are in. If you are at Memorial Sloan Kettering, they will do bland bead embolization. They have done a randomized trial to look at that. If you're at Duke University, you would receive TACE. So there's a lot of uncertainty around which embolic approach is the best. But I think in multifocal disease, particularly small multifocal disease, embolization is a better approach than resection.
I have to add, I love the way Dr. Allen is saying they at Memorial. Probably he was part of that study that we published in JCO. But an important point, however, interestingly, in regard to the choice, the perception of combining embolization plus checkpoint inhibitor probably will work better with a chemoembolization and not with a bland embolization because of the potential activation that chemotherapy can induce into the immune system. And that's really what already we are doing ourselves at Memorial and other groups as well. So I think there was a question there. Yeah.
Thank you very much. In both approaches, the systemic therapy and in the surgical approach, you included the study of factors, the determination of factors concerning the residual function of the liver. But besides that, do you probably the fastest growing group of patients or cause of liver cancer is the non-alcoholic liver disease. Do you consider that an independent factor for the approach either in systemic therapy or in surgical approach?
You want to start with surgery?
I'll start, yeah. So I think NASH, non-alcoholic steatohepatitis, is the growing, if not the number one cause of liver failure in the U.S. now, and is just a major problem. I would say that in terms of surgical approach, it doesn't, a solitary lesion, whether the patient has NASH-associated cirrhosis or Hep C, or that would not really change my mind about surgical resection. I would say in the Hep B associated HCC, which we don't see that frequently, that these patients oftentimes will have a solitary tumor with preserved liver function. And in Hep B associated tumors, the data are actually, those are the majority of those patients who do well after resection of a large tumor. So NASH versus Hep C versus alcoholic, not necessarily, but Hep B with this, in terms of the surgical approach, is something we pay attention to.
Yeah, I totally agree. Even we concur that from the oncology standpoint. Almost 25 years ago, Snorri Þorgeirsson from the NCI in the US suggested that the disease and how it flows in regard to the genetic makeup of it, Hep B versus Hep C versus other like NASH, alcohol, are different diseases. But interestingly, so far we're not able to really get a hand on this specific variation. I would say the Hep B versus others is coming from the fact that Hep B is DNA virus, and as such it does not affect liver functionality, and that's why probably the approaches could differ in regard to surgical intervention. In regard to oncology, in our work that we published last year, we have found that tumors can actually be on a certain genetic alteration pathway, and based on certain stressor, can change to a different pathway. And in other words, they can really decide to be Hep B-like or Hep C-like at any time they want. And for that reason, we're doing an effort now. We don't have the answers to that, but at the moment we really treat irrespective of the etiology. But an effort that we're doing that actually Mexico is proud, contributor and partner of, and Erica is leading it from here in Mexico, is we're collecting tissue from liver cancer patient in 46 countries with analysis on the ethnicity and etiology to figure out what are genetic makeups that can give us probably better views on this.
I want to do a surgical question. Well, actually, two questions. When you have bilobal disease, is there any data to support combined surgery and local regional therapy like RFA or other kind of therapy at the same time? And second, after you have done surgery for this multifocal disease, could you consider this patient in the future to go for liver transplantation?
Yeah, certainly there are many reports of combined embolization and resection. Fit patient, relatively limited liver disease with a very large tumor in segment 3 and 2 small tumors deep in the right liver. You might consider a combined embolization or ablation and resection approach. I think that now working at a center where liver transplantation is a very large group with well over 100 liver resections annually, I am being exposed more to liver transplantation as an option. And the outcomes, if you look at the patients in the U.S. who actually get to liver transplantation and through it, the outcomes are quite good. And so I do think that in these multifocal patients, certainly within Milan, even on the borders of Milan, we are getting our liver transplant group involved very early.
Hello. I'm sorry. I have another question for Professor Allen. It was reference to Dr. Allen's question also, as where do you stand on surgical downstaging therapies like ablation and electroporation, not only for HCC, but also colorectal metastases?
I think that we use ablation quite often, both intraoperatively and in interventional radiology, depending on the disease process. So we prefer resection. We think that resection is if it can be done safely in a margin negative manner, is the most effective local therapy. It removes that tumor. The other therapies, ablation, combined embolization and ablation, or ablation, they are very effective, but they can't be as effective as removing the tumor. So we individualize it to the patient. Tumors deep in the right lobe of the liver in a multifocal setting, in HCC we would consider ablating or embolizing. With colorectal liver metastases, we're much more aggressive with respect to numbers of tumors in the liver that we're willing to try to resect. And we would generally resect everything that we can safely and then consider ablation as a secondary treatment for small tumors, oftentimes close to the vessels. We would use IRE in that situation. But we would still favor resection when possible.
One question, is there any indication for liver-directed therapy in patients that are having systemic therapy for metastatic disease?
So the effort was already looked into, and we're well aware of the combination of the embolization plus sorafenib, with presumably as a quote-unquote adjuvant. They did not work. TASTE 2 and the SPACE study and ECOG 1208, etc. They all were negative. However, your question is very interesting because you're looking at liver-directed therapy plus systemic. And I would say that the effort now was just reported, I believe, in 2018 coming out of China, where it was in JAMA Oncology, looking at the hepatic arterial infusion of chemotherapy plus a systemic. And I think it is a possible visitation, but we're not there yet. So.
I want to do a difficult question because I recently saw a patient like this. Could you consider somebody that had already metastatic disease and have an incredible response with immunotherapy after HCC and I was free of disease like 1, 2, 3 years, would you consider him to go for liver transplantation? I mean, we are seeing a fantastic response sometimes, or not quite often, but some people have incredible.
Are you the one who emailed me a few days ago? Because no, great question. If anything, a certain physician emailed me a few days ago and said exactly what you just asked. And admittedly, because I'm not the world expert on this, so I reached to really the experts we have, and I spoke with Jed Walchuk, who is really, one of the gurus in regard to checkpoint inhibitors. And pretty much it was felt that the effect of the checkpoint inhibitor in regard to the potential rejection of the organ will be at least minimum of 6 months to 1 year. And as such, to really consider somebody on a checkpoint inhibitor for a potential transplant, you got to wait a long period of time from the last dose of checkpoint inhibitors until the transplant, which could be the wait period, 6 months to 12 months. But again, this is all speculative based on only the scientific component rather than any true science. If anything, on the other hand, if we reverse the question, transplant followed by checkpoint inhibitor, the data has not been good. I would like to ask Dr. Bikai Saab, because Mayo claimed that they had experience which was probably positive for certain patients who were transplanted and received checkpoint inhibitors afterwards, but I would say this was not reproducible. I don't know if Connie would like to comment on anything at all.
I think it all depends on the center, right? Now that you're in view, where you transplant, the more you show you don't transplant. So, our transplant surgeons tend to be more aggressive. So they consider the exceptional patient. As long as there is no extra hepatic, as long as there is no extra hepatic disease, then the answer is yes. They would consider transplant.
Give me your card.
For the right patient.
It is my patient, so.
Yeah.
Okay, yeah, sure.
And the problem is organ allocation, right?
Yeah.
Yes.
And,
We have a lot of them in Arizona.
And, the U.S. just went to a new policy of allocation, and so the problem is organ allocation. If you were in a country that had an excess of organs to implant, then I think it would be a different answer.
¿Alguna otra pregunta en el auditorio? Well, thank you very much for your talks. Thank you.